Thank you everyone for joining us today and joining the Cancer Research Institute's webinar series, Cancer, Immunotherapy, and You. Today's date is Wednesday, March 16th, 2016. The title for today's webinar is Critical Advances in Immunotherapy for Kidney Cancer. In this webinar, we'll discuss treatment options for patients with this type of cancer. This webinar series is presented by Genentech and LabAnswer and its employees, along with generous support from Celldex and Regeneron. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. The Cancer Research Institute is the world's only nonprofit organization devoted exclusively to harnessing the power of the immune system to conquer all forms of cancer. We fund scientists around the world whose work has led to significant breakthroughs in the treatment of cancer with immunotherapy. Over the next 30 minutes, you'll have an opportunity to hear firsthand from an immunotherapy expert how these breakthroughs are transforming the treatment of kidney cancer. After a 15-minute presentation from our speaker, we will open the discussion to questions submitted by you. You can pose your questions at any time by typing in the Q&A box on your screen. You can also tweet your questions to us at our handle @CancerResearch and using the hashtag #CRIWebinar. Today's webinar is being recorded and will be made available on the Cancer Research Institute website and on our YouTube channel. Now it's my pleasure to welcome today's expert speaker. Dr. Nizar Tannir is a professor and deputy chair of the Department of Genitourinary Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston. Dr. Tannir has conducted numerous clinical trials in kidney cancer, including the phase 3 trial that led to the FDA approval of a new class of immunotherapies called immune checkpoint inhibitors for patients with kidney cancer. Dr. Tannir, we're grateful that you could take time out of your day to join us. Welcome.
Thank you, Brian. Thank you for the opportunity, and thank you all for tuning in. This is an exciting time for cancer research because of the advent of immunotherapy and why immunotherapy is now taking center stage in the battle against cancer. Well, the immune system can eradicate tumor cells. It does that by its adaptability. So the immune system is adaptable, it is specific, and it retains memory. There are several immunotherapy strategies. Cytokines is one strategy, and that was the mainstay of treatment of kidney cancer for about 2 decades back in the 80s and 90s. Cytokines are proteins that crosstalk between cells. This is how the immune cells talk to each other. And there are also therapeutic vaccines. We're talking here, of course, about cancer vaccines. The immune system is shown markers that we call antigens that are either on the surface of the cancer cells or inside the cancer cells. And this immune system will respond. It is triggered to attack the cancer cells. There is also another strategy that's in the realm of immunotherapy, and that's called adaptive cellular immunotherapy. And this involves T cells stimulated in vitro and so-called CAR T cells. What's the adaptive strategy here? Adaptive means the doctor will remove the immune cells from the blood of the patient, will grow these immune cells outside the body or make changes to them, and then will reinfuse them into the patient to attack the cancer cells. Oncolytic viruses, we're here talking about, again, cancer vaccines and cancer viruses. You may have heard about some of the viruses that are being used actually now to specifically attack cancer cells. And some of this, for example, that has taken a lot of media attention is the polio vaccine used at Duke and other academic centers to attack brain tumors. And the most important recent advances in immunotherapy is using immune checkpoint inhibitors, using that strategy to block the immune checkpoint. Now, what are these immune checkpoint inhibitors? Now, some proteins are referred to as checkpoints or brakes. They put the brakes on the immune cells to dampen the immune response so that the patient's own immune cells do not attack the patient's own organs. And that has been an evolution in time to protect our body from ourselves. But when the cancer cells appear and they're considered foreign to the body, they're identified by the immune cells, and therefore the immune system may not be able to attack aggressively the cancer cells until those brakes that are on the immune cells are released. So this is where these immune checkpoint inhibitors, these agents that have been recently approved for kidney cancer and other cancers, come to play, because they release the brakes so that the immune cells can do their job and attack the cancer cells. Now we talk about the latest discoveries and the advances that have come to the clinic. I'll be discussing with you some of the data that have been recently published that led to the approval of one of the immune checkpoint inhibitors that is approved now for kidney cancer or carcinoma. Here is a list of some of these immune checkpoint inhibitors that we call PD-1 and PD-L1 inhibitors. Now, PD-1 is programmed cell death, and PD-L1 is programmed cell death ligand. These, again, are drugs that will release the brakes from the immune cells to attack the cancer cells. In the class of the PD-1 inhibitors, there is a drug called nivolumab. The brand is Opdivo, and it's manufactured by Bristol Myers Squibb. And it's approved for melanoma, non-small cell lung cancer, and recently, in November last year, kidney cancer. Another similar drug from Merck is called pembrolizumab. The brand is known as Keytruda, and it's approved for melanoma and non-small cell lung cancer. There is also another drug in this class, pembrolizumab, and it's by CureTech, and it's still in its phases 1 and 2. And there is another one, MEDI0680, that's from MedImmune and AstraZeneca, that's also in early phases, phase 1 and phase 2 trials. Now, the class of the PD-L1 inhibitor includes atezolizumab, which is from Genentech Roche, and this trial has gone through multiple phases, phase 1 and phase 2, and recently a phase 3 trial was conducted and completed accrual in kidney cancer. There is another drug similar to this, and it's called avelumab. It's from EMD Serono and Pfizer, and it's now in phase 1 and phase 3 trials in kidney cancer. And there are other drugs in this category, durvalumab from MedImmune AstraZeneca, and BMS 936559 from Bristol Myers Squibb. It's in phase 1. So we'll focus on the drug that garnered approval by the FDA last year in November for kidney cancer, and that's nivolumab. And I will share with you some of the data that led to its approval. So this is the study that we participated in at MD Anderson. It was a large study of 821 patients with kidney cancer who had prior therapy with targeted agents, and patients were assigned one of two treatments, either nivolumab or everolimus, another targeted agent. And the study had for primary endpoint overall survival. And the data is shown on the slide. Patients who were treated with the immune checkpoint inhibitor nivolumab had a median overall survival of 25 months. Patients who were treated with everolimus had a median overall survival of 19.6 months. This was an improvement of 5.4 months, and that was statistically significant in comparison to everolimus. The median follow-up of the study was 14 months. This data led to the approval of nivolumab for patients with advanced renal cell carcinoma. I've summarized for you here on the slide the key features or key data that is important from the study that is known as the Checkmate 025 study. Nivolumab is the first agent to demonstrate overall survival benefit in previously treated patients with renal cell carcinoma. The benefit with nivolumab occurred across all subgroups of patients analyzed and was independent of the PD-L1 expression on the tumor cells. Nivolumab was associated with a higher number of objective responses compared to the comparator everolimus. Nivolumab was well tolerated with fewer discontinuations due to treatment-related adverse events. Also important from the study is that there has been significant improvement in quality of life in patients treated with nivolumab compared to patients treated with everolimus. But there are some side effects, as with every therapy we give to our patients with cancer. There are side effects that are important to be aware of as patients as well as providers. What are some of these common immune-related side effects? Well, one is pneumonitis, and that's manifested by the patient feeling short of breath, having cough, or having chest pain, sometimes fever. On the X-ray, there could be changes that appear like pneumonia, but there are changes that we attribute to the drug. So this would be considered drug-related pneumonitis or inflammation in the lungs. It's best seen on CAT scans. Another important common immune-related side effect is colitis. That's inflammation in the large bowels or colon. And that can be manifested by diarrhea and abdominal pain. Another one is hepatitis. That means there is inflammation in the liver, and that can be manifested by the patient feeling tired and by abdominal pain, sometimes fever. But the way we diagnose this is through a blood test. We see that the liver function test will be elevated, abnormal. There is also a very important side effect that involves endocrine organs in the body. One of these endocrine organs is the pituitary gland in the brain. When it is inflamed, it can lead to deficiencies in endocrine functions. Sometimes it leads to adrenal insufficiency, where the adrenal gland that are over the kidneys, on top of the kidneys, will not be able to produce sufficient amount of cortisol. And that can lead to the patient feeling fatigued or having nausea or vomiting or abdominal pain. And that can lead sometimes to low blood pressure. But the endocrinopathy or the endocrine deficiency can also affect the thyroid gland. And this is where the thyroid hormone in the blood will be at low level. And the patient may feel fatigue or may have cold intolerance or constipation. And these symptoms can be helped by administering thyroid hormone. Hypogonadism is the fact when the testosterone in males is reduced. That can also lead to fatigue, and it can be remedied by administering either testosterone gel or patch or given an injection of testosterone. But there has been also patients who developed, without prior history of having that diabetes, they develop diabetes where the blood sugar can be elevated. And, the manifestation is they can feel thirsty, they can go to the bathroom and have increased urination, increased frequency, and increased urine volume. When there is hypophytocytis, when the pituitary gland in the brain is affected, the patient could have headache or visual symptoms. Rash is another manifestation of this immune-related side effect that affects the skin. It can be also rash with itching. It can be just around the face and the head and neck area, or it can cover the body or the extremities. And nephritis is when the kidneys can be affected, and that can lead to protein loss through the urine, and that can lead to swelling of the legs, or it can affect the kidney function. And sometimes the patient can have belly pain or fatigue. Luckily, these side effects, although they can be very serious if the physician or the treating team does not make the diagnosis in any timely manner, luckily these side effects are not very common in patients. So the vast majority of the patients treated with this therapy, nivolumab, do not have these side effects. Another important phenomenon that's unique to this class of agents that we call immune checkpoint inhibitors is the phenomenon of tumor flare. This is important because it is very important to not prematurely stop the treatment in a patient who is taking nivolumab or a similar drug and is feeling better. And this is manifested by the patient's gaining weight. If they have pain at the beginning of the treatment, the pain is decreased or is gone. If they had tumor fever or chills or night sweats, if these resolve. If the patient had low blood, anemia, and that improved, as well as some other things in the blood, if they improved, such as elevated calcium or elevated blood test called LDH, if that improves. If a patient overall is feeling better, and their performance, their functionality improved, even if the scans show progression, it behooves the physician and the treating team to remember that initially there could be some progression by imaging studies, by scans, but later on, if we continue with therapy and repeat the scans a few weeks later, we may see improvement of the scans that follows the improvement clinically, the patient's feeling better, the subjective improvement. So this is very important. Now, why does this happen? Is because, as I was telling you initially, when these immune cells, I describe them to my patients when I talk to them about this therapy, is they're like the attack dogs. When they attack the cancer cells, there is a battle raging that's going on that can cause swelling of the area where the tumor is. And that can appear on the CAT scan as larger, but it actually is a good thing if the patient is feeling better, because that can be followed later with shrinkage of this area, as is illustrated here on the slide, as you can see. So the T cells, those immune cells, those attack dogs, they invade the tumor, cause some swelling, some release of these things that we talked about, cytokines that can destroy those cancer cells, cause like a soup, like a liquid around, and causes the whole thing to grow. But then with time, the dust will settle and the tumors will shrink. So it's very important to be aware of this phenomena, to not prematurely discontinue therapy in somebody who is benefiting or destined to benefit. I'd like now to share with you a case study. This is a patient of mine that I enrolled on the phase 3 trial, Checkmate 025, that I discussed with you in the slides before, who was initially seen at MD Anderson 3 years ago. He had been treated with one agent and standard of care that we call target therapy, and unfortunately did not respond. So he enrolled on the study and was randomized. That means his treatment was, he was allotted or allocated to receive nivolumab. At that time, this was before the drug was FDA approved. This was the study we conducted that led to its approval. Luckily for the patient, he achieved a partial response. And I could see right after the first infusion, he was already feeling better. And of course, we did the scans and he had a good response, partial response at 8 weeks when we did the first scans. And then this was confirmed later at week 16. And 3 years later, he continues to receive therapy without any toxicity and has achieved a complete response. There is very little thing left on CAT scan anymore where the tumor was. And the tumor was in the area where the right kidney was, and it invaded the liver, and he had spread of the disease to the lungs, and all of these things resolved. And he is now, at 3 years, having no significant side effects and is doing well. But, you know, this is one step forward. We are conducting trials combining some of these agents. So here now we'll review some of the trials that are combining agents such as nivolumab with other agents. So this is a list of some of the trials, and I put the therapeutic combination, the names of the agents that are being combined, the trial identifier. If you go to the NCI clinicaltrials.gov, you can see some of these trials with their trial identifier, NCT, and a number. And I put there the mechanism of action, how these drugs are working, and the number of patients that these trials are trying to recruit. So here you see the title of the slide, Ongoing VEGF-Directed Therapies with Immunotherapy. What's VEGF? VEGF is a protein that's released by the tumor that produces what we call neogenesis or angiogenesis. And that basically, it's a protein that produces or helps form new blood vessels to bring to the tumor the nutrients that these cancer cells need to grow and spread. So that's one of the strategies of treating patients with kidney cancer, is to block that pathway that produces this protein VEGF. So the top line up there is nivolumab plus sunitinib or pazopanib or ipilimumab. This was a phase 1 trial that combined nivolumab with one of these two VEGF-directed therapies and also combined it with another immune checkpoint inhibitor called ipilimumab. The second trial below it is pembrolizumab. I mentioned that to you. It's a PD-1 inhibitor with pazopanib. Then there is the same drug, pembrolizumab, combined with axitinib, another VEGF-directed therapy. That is in phase 1 and phase 2. Then atezolizumab is the PD-L1 antibody I alluded to earlier. And there were 2 studies conducted with this agent. One completed accrual, and it was a randomized phase 2 trial combining it with a drug called bevacizumab or Avastin versus sunitinib, which is a standard of care treatment for kidney cancer. And the phase 2 trial is a much larger trial that recently completed its accrual, and it combined this drug, atezolizumab, with bevacizumab versus sunitinib. And at the bottom of the slide is a trial that we are currently conducting at MD Anderson in patients who present with their primary tumors in place. That is, they have not had their kidney removed yet, but they have metastatic disease. In other words, their cancer has spread already outside the kidney. So we are comparing nivolumab versus nivolumab plus ipilimumab versus nivolumab plus bevacizumab. So it's a 3-arm study comparing these 3 treatment options, and we are aiming to recruit 60 patients to complete the study. We have seen some exciting results already in some of these patients who presented with their primary tumor in the kidney in place and widely disseminated disease, where they had dramatic responses. And we follow in those patients who respond, we follow with surgery to remove their kidney, and they continue after they recover from the surgery. They continue with the single agent nivolumab. I'd like to conclude this presentation by saying that the promise of immunotherapy is here. There are ongoing and future trials will determine the optimal combinations, some of which I showed you. And also, the future trials will determine the optimal duration of treatment. For now, we continue with nivolumab every 2 weeks, indefinitely, as long as the patient is benefiting, as long as the patient is tolerating therapy and is willing to continue with the therapy. But an important question is, how long is optimal duration? How long should we continue, especially in a patient who has benefited, like the patient I shared with you? Should we stop after 2 years? Should we stop after 1 year? These are important questions we don't have the answers to right now, but we are working towards finding the optimal duration for treatment. There are challenges that remain despite the progress made, and the challenges are to identify what we call biomarkers of response and the resistance to therapy, and also managing some of the side effects. I think it requires a team to really understand how these drugs work, to institute management of the side effects promptly to avoid any complications. But I think it's also important to really know which patients benefit the most from these treatments, because unfortunately, this drug nivolumab and other drugs similar to it, they work in some patients and help some patients, but they don't work for all patients. So it's important to understand and identify what we call markers that will help us say, this patient will be best treated with this drug or others. But let me say that while immunotherapy has now been validated as a modality of treatment of cancer, and we are grateful to the research and the collaboration between academia and industry to bring these exciting treatments, these promising treatments, much remains to be done until we cure cancer. And let me say that target therapies will continue to play a role. Immunotherapy will work for some patients, but so far does not work for every single patient. And there are therefore patients who will benefit from these other therapies that are already approved, and some of these therapies that we are working on to bring to the clinic. I'd like to conclude by acknowledging the patients who participate in the trials, who come and who receive their care at MD Anderson, and my colleagues at MD Anderson that I have had the privilege of working with. Thank you for your attention.
Thank you very much for that, Dr. Tannir. It's so good to hear such great, exciting progress being made in development of treatment for kidney cancer patients. And of course, it's exciting for us at the Cancer Research Institute to see immunotherapy being borne out as an effective treatment strategy for some patients, as you said. You pointed that out. And on that note, can you just clarify at which point in a patient's treatment strategy, treatment course, would he or she become eligible to receive the approved form of immunotherapy for kidney cancer?
So the agent or the drug nivolumab, known as Opdivo, as the brand name, it is approved after progression on the target agents I described. So patients who receive, for example, sunitinib or pazopanib, these are the two most frequently prescribed agents for the first-line therapy of patients with kidney cancer. So if a patient received one of those two drugs and they responded, but then ultimately the disease progressed, that's the time when patients will be eligible to receive nivolumab or Opdivo. And that's where the FDA has approved this agent. It's in patients with advanced kidney cancer who were treated and had progression of their disease with the FDA-approved agents, the oral agents, sunitinib or pazopanib.
Okay. And does that hold out? Does that bear out across the many other clinical trials that are testing immune checkpoints in kidney cancer patients, or are some patients being treated before failing or before receiving a targeted therapy?
Yes, it's a good question. I showed some of the trials in the slides that one of the slides had the different trials that are using some of these agents, the immune checkpoint inhibitors, and some of these trials tested the immune checkpoint inhibitors against the standard of care, the approved oral agents in first line. So, for example, a large phase 3 trial was conducted that recruited more than 1,000 patients. This was a global trial that was sponsored by Bristol Myers Squibb, used in the combination of nivolumab, the approved agent, plus another immune checkpoint inhibitor, ipilimumab. So the trial compared patients with the most common form of kidney cancer, that's called clear cell, in the first line setting. So patients were randomized. That means they were assigned one of two treatments, either the standard of care treatment with sunitinib, which was used as a comparator, or the combination of these two immune checkpoint inhibitors. So the trial concluded its accrual last year in November. This was a global trial conducted in many countries, but the results will not be available till 2018. Another trial I mentioned in one of the slides is the trial conducted by Genentech and Roche, and it compared their PD-L1, which is similar to the PD-1, the nivolumab. They compared atezolizumab in combination with bevacizumab versus sunitinib, and that was a phase 3 trial that was also recently completed its accrual last year. Again, the results will not be available for quite some time, probably in 2018 again. And there are other trials looking at similar agents in combination versus standard of care, FDA-approved agents in the first line setting. Our trial that is being conducted at MD Anderson, the one I alluded to, which is a small trial of 60 patients, it's a randomized phase 2 trial, that is also a trial we're conducting in the first line setting. So there are some trials at academic centers and trials sponsored by industry, by pharmaceutical companies, that are looking at administering or testing these agents in the first line setting, and some trials are testing them in the salvage setting after prior therapy.
So it sounds like there are several options, many options for patients that are considering treatment and when to receive treatment with an immunotherapy. So that's great. Can you briefly, very briefly, for the patients that are watching and maybe newly diagnosed and unfamiliar with the clinical trial process, can you just briefly describe the difference between a phase 1, phase 2, and phase 3 clinical trial?
Sure. The phase 1 trial is basically testing either first in human, first in men, they call it a trial, where a drug is believed to be effective or has promising activity against tumors, so that you bring it to be tested in humans. But here we're testing it. Of course, we always have in mind we would like to see it help some patients, and we want to see which patients will be helped. But the phase 1 has a goal to find what would be tolerable. So the goal is to identify what is the maximum tolerated dose of a particular agent. Once that's determined, then we move on to phase 2 trial, which is the trial setting where you know a drug has some activity shown in the phase 1, and you know that there are dose that you think will be tolerated by patients. And then that's the time when you test this drug or this therapy in a group of patients with similar cancer. So it will be a phase 2 trial in kidney cancer, or phase 2 trial in breast cancer, or other cancers. Phase 3 trial is when you have already established some efficacy from phase 2 trials, or sometimes from phase 1 trials, and the efficacy is promising to the extent now you want to take it, test it in large number of patients against a standard of care. That standard of care could be another FDA-approved agent. If there is no standard of care, then against best supportive care. And this is where sometimes placebo can be, tested. And so the idea with phase 3 is to bring a therapy or a drug to the approval process. So you want to show in a large number of patients that the treatment you're testing is superior to the standard of care or comparable to the standard of care, but brings other benefits to the patient, such as maybe less toxicity. If a drug is comparable in efficacy to another standard of care, but it's much less toxic, that would lead to approval by the approval authorities, such as the FDA in the United States.
So on that note, I'm glad you brought up comparisons of trials and their results. Let's talk about quality of life for patients. You mentioned several ways that a patient's health can show improvement over the course of treatment, such as reduction in pain or weight gain for those who have been unable to retain weight. But what is the day-to-day life? How is it different for patients that are being treated with one of these checkpoint inhibitors versus patients who are treated with the targeted therapies or even chemotherapy? I mean, we haven't talked about chemotherapy so much. What can you tell us about that?
So, I mean, the quality of life is a measure of two things. You have the patient who has cancer, and the patient is receiving a therapy. And so what affects the quality of life of a patient on a daily basis, ongoing during the course of their treatment as they fight their cancer, is very much influenced by the activity of the cancer. Is the cancer active? Is the cancer progressing? Or is the cancer responding to the therapy? And then the other aspect is the side effect of the therapy. So for every patient on any given moment during the course of treatment of their cancer, those are two things that are at play. If the treatment the patient is receiving shrinks the cancer, puts the cancer in the corner, causes the cancer to regress and go away, and if the patient had, before they started that treatment, symptoms as direct result of the cancer, such as things we were saying, pain, fatigue, nausea, weight loss, all those things, fever, night sweats, chills, common symptoms in patients with advanced kidney cancer. If the treatment works and those symptoms that the patient was experiencing before starting treatment will go away, that will translate into improved quality of life. But also the impact of the therapy on the patient can also affect quality of life. And that is due to the potential side effects of the treatment. So it's a balance by how much are you causing the cancer to go away and therefore improve the symptoms that are directly related to the cancer, and what are the side effects of therapy that are impacting the quality of life of the patient. So obviously what we like, the ideal therapy is a therapy that will make the cancer go away or reduce it, put it in remission, or at least controlling it, and therefore improving the symptoms from the cancer, but also reduce or minimize the side effects from treatment. That will be the ideal therapy, and there are tools of quality of life we administer during the conduct of a clinical trial to help us gain knowledge about how the patients are feeling. And sometimes this is important, and sometimes this is important information to take to the FDA if your drug is not superior to another FDA-approved drug, but results in less toxicity, results in improved quality of life. There have been many therapies, many drugs approved in the past by the FDA, not because they cured patients or they prolonged life, they prolonged survival, but because they improved quality of life, such as reducing pain or other important aspects of quality of life.
Okay. Well, we're almost out of time, but I do have one last question for you, submitted by one of our viewers. So the question is, from the patient's perspective, what are the costs, if any, involved with enrolling in a clinical trial, or what may be some of the hurdles? Because of course we know that there's an abysmally low enrollment rate of eligible patients in clinical trials. So what are the factors that make it difficult for a patient?
This is a very timely question, very important question for our patients. I think first I would like to advocate for participation in clinical trials, especially in oncology. It would, all those advances that we have achieved against cancer, whether kidney cancer or other cancers, would not have been possible without patients participating in clinical trials. So I think I would like to advocate and encourage patients who are listening and their providers, their families, and we encourage our colleagues, physicians in the community, as well as academic centers, to also enroll patients on clinical trials. But I think the cost of clinical trials is now becoming important as society grapple with the rising cost of healthcare. And people wonder, why are some of these cancer drugs so expensive? Let me just give you an example of how expensive it is to conduct a phase 3 trial. We spoke about phase 3 trial. Several hundreds of patients treated, and we're testing immunotherapy versus standard of care. It can cost up to $100 million to complete a phase 3 trial with the goal of bringing new therapy to the clinic for our patients. So research, cancer research is expensive. And unfortunately, there are some insurance carriers that do have restrictions, put restrictions on patients' participation in clinical trials. You have to really look at your policy and read in the fine print whether your insurance allows you to participate in clinical trials. The good news is Medicare, the largest provider for patients in the U.S., does not obstruct or restrict patients from participation in clinical trials. Now, to actual cost to a patient, let me just be clear, because there are a lot of misconceptions out there that if you participate in a clinical trial, you're going to be treated like a guinea pig. And I heard that so many times from patients. Nobody is trying to use a patient as a guinea pig here. Clinical trials are the venue to offer you promising, exciting therapy so that you can live longer and beat the cancer and get a drug to FDA approval so that other patients in the future will benefit from this therapy. It is important to say that if a trial is sponsored by industry, by a pharmaceutical company, and it's a novel drug, a new drug, the drug is provided free to the patient. So there's no cost to you there. And then several of the tests we ordered within or in the context of the trial, they are standard of care tests. So they're done scans, for example, CAT scan of the chest, abdomen, pelvis, blood work, etc. It's all standard of care that is billed or billable to Medicare and your private insurance. It should not be denied by insurance. Now, some of the tests that are not standard of care and they are research, the cost of these are borne by the industry, the pharmaceutical company that's sponsoring the trial, or the academic center that's doing those tests. So there should be no cost to you to do these research tests or to do the standard of care test. Now, some trials, the phase 3, large phase 3 trials, some companies do actually pay or cover for travel expenses, but that's the exception. That's not very common to see that a big the drug company pays for the patient's travel expenses. So I encourage you to consider participating in clinical trials and encourage your families, friends, neighbors to do the same. Only through research we can advance the field and cure cancer.
Thank you. Thank you very much for that. That is a message we believe in very strongly at the Cancer Research Institute. Dr. Tannir, this has been a very fascinating 40 minutes on kidney cancer immunotherapy, and I like the areas that we were able to go into with questions. So we'll need to wrap this up today. Unfortunately, I'm unable to get to all the questions that have been submitted by our viewers, and I apologize for that. So first, I'd like to once again thank our presenting sponsors, Genentech and LabAnswer and its employees. And I would like to thank Celldex and Regeneron for their generous support. We heard a lot about clinical trials today, and I'd like to share our resource for patients and caregivers at www.theanswertocancer.org. This is a site that explains what immunotherapy is, describes various types of immunotherapy based on the type of cancer that a patient or caregiver is interested in learning about. It features an ability to connect with immunoadvocates. These are patients, other patients who have been treated previously with immunotherapy and have made themselves available to answer any questions you might have. And there's also a clinical trial finder. You can dial this phone number and be connected to someone who will help you navigate the many immunotherapy clinical trials that are now available, and hopefully get you enrolled in one of those if that is what makes sense for you, and that's part of the discussion that you have with your medical providers. So all of our webinars, I'll remind you, are recorded and will be made available. You can view this and other past webinars at www.cancerresearch.org/webinars, and you can also register for upcoming webinars where we discuss immunotherapy for other types of cancer. Once again, Dr. Tannir, thank you very much, and I thank all of you for joining us today. Goodbye.
Thank you.